Dr. Felicity Sapp is Clinical Director and owner of OCD and Anxiety Psychological Services in Calgary. She has extensive experience treating children, teens, and adults with OCD. She's a board member of the Scientific Advisory Committee of Anxiety Canada and a credentialed member of the Canadian Association of CBT. She provides training supervision to therapists as part of the Pediatric Behavior Therapy Training Institute for the International OCD Foundation, and annually, since 2008, presents OCD and anxiety-related workshops in the USA and Canada. Thank you, Dr. Sapp. It's all yours.
Okay. Well, I just want to thank everyone for coming this morning. I know it's early, and as Julian mentioned, this is the second webinar that I'm presenting in a series. I'm kind of assuming that people have seen the first webinar or attended it, because in that first webinar, I sort of talked a little bit about what we need to think about before we start treatment. And in this webinar, I'm going to focus more on the exposure and response prevention treatment and how to develop and implement effective ERP. So these are my disclosures. Now, in terms of what I'm hoping you'll get from this webinar is that by the end of it, you'll be able to describe the steps of ERP treatment and to be able to create individual fear hierarchies related to a specific fear and then be able to implement ERP treatment from that, and to apply and adapt creative techniques to ERP treatment based on the age of the child or the teen. You know, we know that OCD affects anyone. It really does not discriminate. You know, here it is even affecting Santa. You know, he used to only check it twice. Now it's 5, 6, 7 times. Come to bed already. So it's when OCD starts to affect your life that it really becomes a disorder. You know, we sort of hear these comments of, I'm so OCD, and you know, here we have, no, ma'am, having OCD is actually different than being a little bit finicky. And it's these types of comments that tend to really diminish the true challenges that people with OCD actually go through. And the truth is that OCD is a true mental health disorder, and it can be quite debilitating. I talked a lot about how the brain is part, and understanding the brain to understand what's going on with OCD. So just briefly, understanding that OCD is a neurobiological disorder, which basically means that the way the brain, it's way the brain has become wired at this time. And the amygdala is sending off a false alarm. It triggers the fight or flight response, but even though it's a false alarm, the body acts as if the danger is real. So what the youth is feeling is 100% real. So if we're going to try to take back control from OCD, we have to retrain that amygdala to stop sending the false alarm, and we need to change the wiring in the brain. In the last webinar, I talked a lot around the cognitive therapy, you know, teaching the youth how to respond differently to the obsessions. And in this in this webinar, I am going to focus more on the behavioral therapy, changing the actions that are used to decrease the anxiety. I'm sorry, my slides seem to have a mind of their own, so we'll just deal with that. So in general, behavioral part of CBT is something called exposure and response prevention. And that is where we expose the youth to the triggering situation, place, thought, urge, or object while they're being encouraged to not engage in the ritual. In order to do this, we need to know what the core fear is. So we ask lots of questions to identify that. Using their journal, we identify the triggers and avoidance behaviors that they are engaging in. We rate each of these using a fear thermometer or an anxiety scale, and we arrange these triggers on either a bravery ladder or a hierarchical scale related to one specific fear. And then what we want to do is start with the items on the lower end of the scale and work our way up. And the reason we want to do that is that we really want to have the youth to experience that they can tolerate the anxiety levels. So by starting lower, they can tolerate it, they experience success, and that increases their motivation and their confidence to want to continue with treatment. So we have found that in the adult exposure therapy literature, that when you look at using a compound exposure approach, which basically means that we're going to expose the person to one trigger and then to a separate trigger, and then follow it by both triggers simultaneously. So I might be having them listen to gagging sounds and maybe looking at a picture of somebody who looks like they're going to be sick. So they would do each of those as an ERP task separately, and then I might put them together. And when we do that, it maximizes how quickly the person is going to habituate rather than only using one type of single trigger. People sort of think that we have to wait to the end of treatment before we can expose the client or the patient to the highest rated triggers. But the reality is that we often are doing that partway through the treatment. Because by doing this, it allows them to have opportunities to experience the fears and the triggers in various situations. They can generalize it to different contexts and to different situations and practice it outside of the treatment process. And it allows them to really have opportunities to apply it to real life. When I'm talking with children and I want them to kind of understand the goal behind ERP, I want them to kind of understand that, you know, when you first start facing this trigger or not doing your ritual, or you're going to feel an icky feeling and it's not going to feel good. But if we don't listen to what OCD wants you to do, then eventually that icky feeling is going to come down. And so I want them to kind of get that visual of that. And really, when we think about what's happening over here, it's the idea that habituation is occurring and the youth is feeling, and the amygdala is feeling the anxiety coming down. And so in order for the amygdala to learn, it needs to feel the anxiety coming down naturally, which is what happens during ERP. And it needs both within trial and between trial habituation, which means we're going to have to do repetitive trials of that same exposure to retrain that amygdala. So the different steps around ERP is, first, we want to expose the youth to the triggering situation or object. We want them to let their thoughts come. We want to identify what those thoughts are. You know, what if I take this knife and stab someone? What if I lose control? I must be crazy. We want them to then rate how uncomfortable they are on an anxiety scale or a fear thermometer, and then record how long it takes for that anxiety to come down. And while they're doing the exposure and response prevention task, we want them to allow whatever scary thoughts come there, not to push them away, and also to allow whatever feelings there are. It's super important when we're doing ERP that parents and youth realize that they cannot engage in behaviors that's going to help them feel better. So we don't want them doing any relaxing breathing. And particularly, we want the parent to understand that we don't want them rescuing the child from the anxiety. Now, Dr. Paul Munford, he talks about these as false fear blockers. And the reason that he calls them false is because they're not actually blocking the fear. All they're doing is prematurely stopping the anxiety rather than letting the anxiety come down all by itself. And so if the anxiety doesn't come down by itself, then habituation is not occurring. Part of what we want to do here is let that anxiety come down and have the parent sort of as a helper, and then reward the child for being brave, or the youth. And I'll talk more about reward in a moment. So really the goal of ERP is we're retraining the amygdala. We cannot talk the amygdala out of its fear because it's in the feeling part of the brain. So it needs to feel that it's not dangerous. If we act as if the situation is not dangerous by staying in contact with the trigger and not doing the ritual or whatever OCD says to do, then the amygdala will learn by feeling the anxiety coming down, and that's how habituation occurs. Practice makes routine. We need to do it repetitively. And through doing ERP, the youth is going to learn that if they don't engage in the compulsion, that anxiety, it came down by itself. They also begin to tolerate the anxiety better than they thought they could. And they also learn that their feared consequence does not necessarily happen. And then once it learns all of that, and the amygdala feels that it's not dangerous, then it will stop sending the false alarm. I just want to go through some common pitfalls we see sort of new therapists fall into when they're implementing ERP. First of all, not sort of recognizing in the ERP session or just in general if the youth is actually doing mental compulsions, and then not being able to teach them what do you do instead. So how do you resist them? Unintentionally providing reassurance for the patient, and not being able to recognize how far and when to move patients into higher anxiety-provoking situations, and also putting them into higher anxiety-provoking situations when they're not ready for it. So that training is really important. Not engaging significant others in treatment when it's needed. And so parents and sometimes siblings need to be brought in for treatment into the treatment process sometimes. And they also need to understand what's going on in the brain and how to respond differently. And also sometimes we need to have parents informed of sort of some of the different types of triggers they're going to use. So you want their permission on some of those things. And then again, we have to look at if parents might be interfering in the treatment process, we're going to have to include them in terms of there's any accommodating behaviors. Therapists might not be using imagined exposure effectively, allowing distraction or relaxation during ERP, and then getting into a situation where they're kind of arguing with the youth, or they are trying to challenge the reality and rationalize with the youth around the content of the obsessions. Now, in 2019, in the UK, a study was done by Kelleher et al., and it was looking at the different factors that impacted the use of ERP by clinicians. And what they found is that it was actually the therapists' negative beliefs that were actually getting in the way of them using ERP. So these were negative beliefs like the idea that bad thought obsessions are inappropriate for ERP, that it's not safe or it's not ethical to address them because maybe the patient is unable to tolerate the anxiety, or it's kind of mean to actually expose them to the content of these obsessions. They also will feel that maybe the patient can't even tolerate the level of distress that they have, and so therefore they need to teach them anxiety reducing techniques to help them feel better during the ERP. So they would allow calming breathing. Just going to go back for a second there. So it really is important to have that proper training and really understand all of those different pieces around ERP and helping the client stay with that anxiety. The first webinar I talked about was getting ready for treatment. I'm going to focus on rewiring the brain and then kind of taking it into the real world. So basically, as I was mentioning, we're fixing that false alarm through exposure and response prevention tasks. There's 4 different aspects I want to talk about. And but before I do that, I want to talk a little bit what a typical session is going to look like. At the very beginning of the session, you want to check in with the parent and the youth. Again, it depends on the age of the child, whether the parent will be checking in, but in general, I usually will have a few minutes to check in with both the youth and the parent. And then again, depending on the age of the child, I'll then either just see the youth or have both of them there while I review kind of what was it that they did for the last session around ERP. We'll talk a little bit about that. We'll sort of troubleshoot, make changes. It really is important, though, that you address what you assigned, because it makes them feel accountable. It motivates them because you're showing a lot of interest. And then, of course, there's lots of praise as they are successful. During the session, you really are testing out new ERP tasks. The majority of the session is doing ERP. And You want to do this because you want to make sure that whatever ERP task you're going to be assigning isn't too hard, that the youth is able to manage the anxiety. So you're going to do that with them. And while we're doing this, you're going to determine, okay, was this too hard or too easy, and make adjustments. And then, of course, discussing what that new assignment will be that they're going to do before they come next time. Sometimes if I have teens, I will actually get them to sort of tell the parent when they come back in. So when I'm talking to the family and I want them to understand about planned ERP, it really is the formula or the gold standard that fixes that false alarm that's happening. I want them to understand that you have to feel upset, you have to feel uncomfortable and distressed, because then you know you're doing ERP correctly. If you're not feeling any distress, you're probably not doing it correctly. We want to stay in the trigger situation long enough for the anxiety to decrease at least 50% if we're going to retrain that amygdala. And we need that repetition and that consistency, because the amygdala does not learn instantly. I often say to people that once we put an ERP task on the table, it stays on the table. So we don't go back. We don't go back to avoiding or doing what we were doing before. I want them to understand that it's like learning a new skill. If you practice it once a day for a week, or if you practice it once a week for 7 weeks, which one are you going to be better at? And whether that's their hockey, I'll put it into if they're interested in hockey or dance, and have them kind of understand and answer that question. And then I really want them to understand that you don't have to do this for the rest of your life. We're only going to have to do these planned ERPs until the brain is retrained. And then it's reduced and we don't have to necessarily do it. So typically we want to assign about 30 to 45 minutes of planned ERP for a child, 40 to 60 for a teen. And the reason we're assigning this long is because we want the sessions to be long enough that there's several trials happening around the same idea, the same fear, and that allows them to experience both that within and between trial habituation I talked about. I want them to understand that the more you do, the faster you're going to get better, the faster you're going to retrain that brain, and then you don't have to come in and see me anymore. I want them to understand that, I talked about this earlier, that we're going to test out the sessions in session, and then they're practicing those outside. And then, of course, I want them to be rewarded for any of this kind of brave behavior and for bossing back OCD by doing these ERP tasks at home. So, and I'll talk more about the rewards in a moment, but it's what we really do find is that it is actually there's more success the more that the youth is able to complete ERP assignments outside of session. It will predict success more so than just within session compliance. So we really do need them doing these things outside of the session. Now, day-to-day ERP, I want them to understand that, every time that OCD shows up, you're not going to just stop and then sit for an hour and let that anxiety come down. We have to know, how do we manage OCD as it pops up during the day? And so one of the biggest things is to help them understand, how do we manage those automatic mental rituals, and the importance of kind of bringing on the fear and neutralizing them, and not using distraction or reassurance to feel better when OCD appears through the day. So we really do need to assign day-to-day ERP tasks. That's not done at the very beginning of treatment. It's done fairly quickly, but first we need to have them experience the success of it. Often I'll have triggers just in the background of their day-to-day living so that they're just constantly exposed. So on the phone, I might have their screensaver be a picture of their fear or feared object or situation. I'll often incorporate the parents to trigger the youth throughout the day, so that they might be saying the feared words randomly throughout the day. And then I want them to understand that when they are triggered, we want to respond to that obsession with uncertainty. We want to allow that fear to be present. Yeah, maybe something bad could happen, maybe not. And then allow the youth to feel the anxiety And then once the distress has just come down a notch, then they can move on with their day. Oops, sorry. And then also to note in their journal, not just the times where OCD is beating them, but when they actually boss that OCD. So I'll often have like in their journal, they'll have a section that is like brave behaviors where they write down all the challenges they did, or we'll have a big board, a big brave board, and we put stickies on it or something like that, just so that they have see that success. Now, imagined ERP is where we are trying to imagine the situation rather than real life ERP or in vivo. And we find that if we include it as well as doing in vivo ERP, that we're going to see that the gains are maintained longer. It can be used as a first step before we start real life ERP. So it allows the youth to become comfortable with sort of those uncomfortable feelings in a non-threatening situation. It also can be written at various anxiety levels. So we can, depending on sort of how much detail we put into it, the more detail, the more anxiety provoking. And it really allows youth to face fears that we just cannot create in real life. You know, I'm not going to have the youth throw up if they're afraid of throwing up. I'm not going to have harm come to mom, but we certainly can imagine it. And what it really does is it has them engage in these thoughts that they've been avoiding. So it kind of breaks that false alarm idea and allows them to eventually habituate. So these are things like, you know, telling stories or making up stories, writing stories, making a movie, acting out the fear, comic strips. And it's kind of like if you watch a scary movie, the more you watch the movie, the more times you watch the movie, you sort of know what's going to happen. And then you also kind of see new things about it. And eventually you get bored. And so that's sort of the same idea here. Because OCD does not just affect the person who has it, it affects the whole family. We have to look at if the family and how the family might be involved. This is a scale that we can use. I talked about it last time. And what we want to do is then set up a contract with the parents or the family member and the youth to reduce their accommodating behaviors. It's really important for parents to understand that you can be understanding of why your child might be having a meltdown or why your child might be being upset. But we still, as parents, you still have house rules and you still have expectations regarding behavior. And we don't want to stop that just because it's OCD. And the other thing we want to have families understand is it's really important to try to normalize life as much as possible for the youth. So I talked about Sally last time. What I'm going to do now is go through the case presentations I did last time, but in more detail. So Sally was that 9-year-old that we talked about last time. She had a fear of vomiting. There's a family history of anxiety on both sides, and dad and her brother. She was initially diagnosed with severe OCD. There was a lot of family conflict happening because there was high levels of distress. And so in order to keep the peace, parents were really kind of having to keep to the demands, giving into her demands. So her obsessions were, you know, what if I get germs from school on me? What if I get sick and throw up? She was washing her hands excessively, asking lots of questions, and avoiding anything to do with school or things she thought were contaminated. So for Sally, because of her age, we came up with a really cool nickname. This was Mean Machine that I talked about last time. And helping her understand it as a bully, using kind of child-friendly terms that's been bossing Sally around, and she's tired of listening to Mean Machine, and now it's time to take back control. She was, because of her age, rewards and using an incentive program was really important. She was basically would earn points for being brave, and then she could cash those points in for other things. We used games to try to make bossing back fun, well, fun-ish, I should say. But for her, it was really important that we made this kind of worth her while. So we had the incentive program, we had kind of the games to try to motivate her to actually do this work because she really didn't want to. So I wanted her to understand that we're going to learn some tools that we're going to use to fight back Mean Machine. I don't have it with me, but I often will make a fear thermometer in the session with them so that they have a concrete fear thermometer that they use at home. We'll draw. So I like to sort of use concrete objects for them, especially at this age. So the journal, they get a nice new one. We make a map of her life and we create that hierarchy, that bravery ladder. Now, it's really important for them to understand, the tendency with anything we're afraid of is our tendency is always to want to go around what we're afraid of. But when it comes to OCD, the only way to get over the fear is to actually go through it. So I need Sally and her parents to understand this, that the only way is to face it if we're going to erase it. OCD wants you to be 100% sure that what you're afraid of isn't going to happen. So I need them to understand that because there's no such thing as certainty, the only way to take back control from OCD is to accept the possibility that the fear or the obsession could be true. I want them to understand that we don't want to argue with OCD. We don't want to rationalize or try to figure out how contaminated or how dirty something is, because OCD will just bring back that doubt and it will win the argument. So we kind of want to do the opposite. So with Sally, I asked her to sort of be a detective and investigate Mean Machine through her journal. We asked lots of questions and we found out that her fear was really of getting sick and throwing up, but not that she was afraid of dying or anything, but that it was gross. So we created a bravery ladder around her fear of vomit. And I showed this to you last time, so I'm not going to stick with it long. But basically, we started on the lower rungs, we worked our way up. And part of what I did is when we sort of get to those set types of triggers where there's sort of the same level of anxiety, then I'll sort of have Sally help me choose which one we're going to go after, just to kind of get her involved and again, increase that motivation. So for Sally, some of the sample planned ERP tasks were we played matching games. We made cards of pictures of, we start off with emojis, and then we had animated pictures of people looking sick, and then people throwing up, and then real. And we played games. We played hangman with the feared words and phrases. I had her doing arts and crafts at home where she would have to create posters related to her fears. We watched animated videos. We started touching the contaminated items. We tried to make it fun by playing follow the leader, where she would go around or I would go around and we would touch items that OCD didn't want, or Mean Machine didn't want her to touch. And then we started eating Skittles off these contaminated items. It's really important that when you're testing out the ERP in the session, that you actually model that task for the child. So I'm eating Skittles off the floor or wherever we decide. And we want the parent to be involved as well, so that the child can see that everyone's kind of involved and able to do this. Some of her day-to-day ERP tasks were putting up pictures of like these trigger items. We made posters. And so the arts and crafts that she created for me, we actually had her make sort of a wallpaper of them in her room so that she would see them every day and she would have to kind of look at them and go, feel the uncomfortable feeling. Yep, that could happen, and kind of move on. I had them listening to, started off with gagging and then eventually to vomit sounds while she was doing her homework, kind of just in the background. Even while we were in session, there was this throw up song. I was going to play it for you, but I thought it would take too long. But it basically, we would listen to this song that's kids like, oh, let's all throw up. And we would act it out or I'd have it just playing in the background while she and I were doing something else. And then having mom and dad sort of triggering her multiple times through the day. Now with Sally, we came up with an imagine scenario, and we basically had her write a story. And so she wrote a story where, and I'll just read the beginning, like one night, Felicia is reading in her bed. Before she goes to sleep, she claps her hands and her maid turns off her light and leaves. Felicia falls asleep quickly, but in the middle of the night, she wakes up feeling nauseous and smells puke. All of a sudden, she turns over, facing the ground, and pukes. So we're using the feared words, we're making her worst fear happen. And basically, it is important that at the end of the script, we kind of leave it with uncertainty. So she would want to say something like, I know that I'm going to have to go to sleep at night. And it's possible that I may wake up in the middle of the night and puke. I mentioned earlier how much parents were involved in and accommodating behaviors. So one of the big ones was just kind of feeling her forehead, giving her reassurance that she wasn't sick. So before we went after that, we needed to figure out how much it was happening. And so we did a baseline of time, seeing how many times it was happening the whole day. Then we broke it down into sort of time periods, and then gradually started at night, reduced it there first, and then we moved on to other time periods. Part of the contract was that mom or dad was to allow Sally to sit with the uncertainty and to feel the uncomfortable feelings and to not rescue her. And that Sally agreed that she would let herself feel the icky feelings and she would rate on her fear thermometer how she was feeling. And then that she would be rewarded for being brave. Now, so we set up that token or incentive program like I was talking about earlier. The reason we want to use this incentive program is because we know that children are well, first of all, it's extremely effective when we're working with children or youth and even teens, and that they're more receptive to reward than punishment. It's super important that we have the child or youth involved in picking out the rewards so that it's very so that it's very motivating for them. So they would come up a list of small rewards, medium rewards, large reward, and then Sally would earn stickers or points or chips for bossing back Mean Machine and cash them in to buy an item from her reward list. With the younger children, it's important that the points or whatever we're using is given immediately so that we can tie it to the behavior. We don't need that as much with the teens, but with the young ones, it's more important. So with Sally, we found out that she was doing about 50 questions a day, and we wanted to reduce it. So she was given 50 tokens at the start of the day. And every time that she wanted to get reassurance, she would have to give mom a token. So mom would cue her and say, are you sure you want to give up a token? And then at the end of the day, however many tokens she had, she would use those to purchase small rewards or save them for larger ones. And then as we were reducing, she would be getting less tokens as well. Anne, I talked about her again last time too. So Anne was worrying and doing, again, a lot of reassurance seeking. There was anxiety on both sides. Her OCD was in the low end of the severe range. And she, again, was getting accommodating behaviors from parents. So for her obsessions, she was really worried, like, what if I said the wrong thing? What if I offended, my friend at school? What if I'm having these bad thoughts? It must mean I'm bad. What if God punishes me? She was confessing constantly to mom the need to tell, the need to confess about these thoughts. There were repetitive behaviors happening, and she had to check to make sure she didn't offend. So her fear was that she was afraid of hurting people, that she was a bad kid for having inappropriate thoughts about her parents. So some of the inappropriate thoughts she were having was around sort of sexual thoughts. And then she was afraid that God would punish her for having these thoughts. So through her journal, we identified triggers. I had shown you her bravery ladder before, but here it is again. Her planned ERP tasks were, well, I mentioned earlier the importance of sometimes including parents in the decision of what we're using for triggers. So mom actually brought in this book, Where Did I Come From? And we used pictures from that book. We did arts and crafts around the bad words and pictures. She was afraid of sitting on the same toilet that other people had used. So we had her sitting on it and kind of doing a wiggle dance while she was doing it. We had her playing, like doing a dance with everybody, and they were kind of doing the bump. And then in session, we practiced kind of bumping into each other's bums, and her, me, and mom. And she was afraid from sitting on the toilet or these things that she might become pregnant. So we looked at pictures of pregnant bellies, first from the book and to sort of real people. Her day tasks were basically making a collage of those bellies once we had them. She had to sit on the couch where her dad had sat throughout the day. She had to, when she was playing games, to cheat. They would play charades. They'd act out the feared words. She was a very musical girl. And so she actually created a song about her feared content. She used, I think it was like Garage app or something, and created this song, and then she would play it over and over and over again. I mentioned the confessing. So first we needed to find out how much that was happening. Again, we reduced it by starting with certain time periods, and we changed how mom was actually responding. So instead of mom telling her it was okay, mom's response was like, well, maybe God is upset, maybe not. We wanted to look at how much parents were participating in rituals at bedtime. So first of all, I want to get very specific details about the ritual. I want to know how many times it's happening, like as the exact wording, how many times they have to say it, what does mom say, or dad, what does she say? And we had to kind of, once we have that very particularly written out, then we can make small changes to that and then reward her for being brave. Julie is interesting. She was initially seen when she was 13 years old because she was having these harm obsessions. And she completed treatment, but every 4 to 6 months, she'd sort of have a relapse and she'd be coming back in. And I remember thinking that she must not be doing ERP correctly. And it seemed to me that was happening. And she'd come in for a few weeks, she would, do some treatment, and then she'd go off. And I believe she was, because she was a very smart girl, she was using mental rituals. So I believe that she was kind of using mental rituals to feel better. And then of course she hadn't retrained her amygdala. So what was happening is OCD would rear its ugly head, and then she'd come back in sort of in crisis. And again, this repeated for several years. Finally, when she was 16, she came back and admitted that, yeah, I actually wasn't doing ERP. And so, I told you I was, but I wasn't. And so I really wasn't that surprised. But at this point, she was experiencing very violent, intrusive thoughts for a couple of months and was now motivated to resume. So before I talk about her, I want to just talk a little bit about what do you do when someone is resistant? Really, the whole goal is we want to try to increase their motivation. So I will talk a lot about, how is OCD impacting your friends when you're with your friends, your schoolwork, your relationship with your parents, and what would life look like if OCD wasn't bossing you around? Again, I've talked about trying to make ERP funnish. We even can do this with teens by playing games, by using technology. I use a lot of technology with teens. Sometimes we might have to reduce the amount of planned ERP tasks they're doing and just kind of more help them incorporate into their daily life, or really involve the parents as well. And then of course, the token economy type of idea that I talked about earlier. Okay, let's go back to Julie. So her obsessions was that she truly wanted to stab her parents or others, and that she will lose control and act on this unwanted impulse. So she was really believing that this was true, although deep down she knew it wasn't. But when it came, she really felt like it would be, that she would act on it. She was, like I mentioned, very smart. She had a lot of mental rituals. So she would push away the thoughts, she'd distract herself, she'd talk herself out of the fear. She took pictures on her phone as timestamps, and then she had this need to tell about when she had these thoughts. So I showed you her hierarchy last time. So some of her planned ERP tasks were that we started with looking at pictures of knives. We started with very simple knives, just looking at comic knives. I actually had her coloring knives. I had her, again, creating a collage of them. We got to looking at pictures of bloody knives. We had pictures of someone holding a knife in the stab position. And then we started looking at real knives, and we started holding real knives. And then we started putting them in the stab position. And then we included the picture of her mom and had her using the stab position and getting closer and closer. Had her watching scenes of people that she was, of movies that she was afraid of, and then deleting those screenshots or timestamps. For her day-to-day ERP task, really reducing that reassurance seeking, that token economy I talked about that I used with Anne, I used with Julie, and it went really well. It was like toonies and loonies. We had her keep a knife in her bedroom all the time so that there was always that possibility she could take that knife and stab parents. Had her volunteer, had her chopping vegetables when she was around her parents, and to create a collage of teens who had murdered their parents. And any time that she was triggered, to sort of agree that I'll never know for sure. It's possible that because I'm having this thought, it means I want to have it and I may act on it. Okay, so Mike, he was a 15-year-old. He was having sticky thoughts around morality. He was in a new school where he was seeing teens kind of doing bad behavior. So he was afraid that he might engage in these behaviors and would act immorally. So he would mentally review to make sure he didn't do anything wrong, and a lot of confessing. So his hierarchy, I think I showed you this at the last webinar as well. So some of his planned ERP tasks is we had him looking at pictures of alcohol, of weed, of vaping, and then we brought them in and had him looking at, cigarettes, looking at vapes, and then touching them, and then holding them, and then mimicking the use of them. Had him looking at pictures of teens partying and sitting with the possibility that that could happen to him, or that would be him. Watching scenes from movies and TV shows that he wanted to avoid, and TikTok videos, and pictures of the devil. His day-to-day ERP tasks were collages of the pictures and words, not confessing when he had a bad thought, playing games and cheating, telling white lies, and going to those Instagram sites that he wanted to avoid. He had to say curse words multiple times in the day. His parents would say those words and text them to him, just to kind of constantly trigger him. Even with teens, we want to try to make this less onerous. And so in incorporating technology, incorporating games and parents, card games, Pictionary, charades, acting out. Now, Mike was extremely artistic and he liked film. And so what he and his parents did is they created a film and they acted out a scene of them, drinking and vaping and cursing while playing cards together. And then they shared that with me. And so anytime he was triggered, we wanted him sort of agreeing, I'll never know for sure. It's possible I may be acting immorally, and it's possible I may end up an alcoholic or a druggie. So the goal here, what do we do with unexpected triggers? You want to use these as unplanned exposures. So social media, magazines, if they hear a song about their trigger, you want to get them to let you know about that and develop an ERP task around it. It's super important that the youth responds with uncertainty. It's possible I might be just like this murderer. It's possible I may stab my dad, and then not to do anything to feel better. Let's talk a little bit about relapse prevention. So the whole goal is to establish the child and the parents as the therapists and the coaches. We want them to understand, how did you take back control? Kind of review that and have them understand that, be on guard, don't become complacent here. OCD especially likes to sneak back in during times of stress or change or transition. We want to create a relapse prevention plan. What are we going to do to keep OCD at bay? What lifestyle changes are you going to do? How are you going to reduce stress? How do you make yourself less vulnerable? If OCD tries to sneak back in, what are we going to do? So I want to, and I will ask them questions, what would be the clues that OCD might be sneaking back in? And I want to hear what they say. What would you do if? And remind them that, yeah, you now have the tools. You didn't have them before, but you do now. So it's not going to be the same as when this all started at the beginning. And understanding that it's okay for OCD to win sometimes, that expect that it's going to win sometimes, and that it's okay to come back in and have a tune-up. Just like we tune our skis every season, you can come in for a booster session. As a therapist, what tips do you want to share? Well, you want them to understand that the more they try to push away the obsessions, the more they're going to return. So don't even try. You want them to change their perspective of how they're responding to OCD. We want to do the unexpected, the opposite of what OCD wants. I will sit on that couch after Dad did. I am staying at school even though someone was coughing. I am going to use this knife even though my mom is around. Dr. Reed Wilson talks about OCD playing mind games with people. And so you need to fight fire with fire. So if OCD is going to play mind games, you're going to play mind games back. So instead of doing what OCD expects, rationalize or arguing, you're going to just agree. It's possible that I'm not a good kid. I may throw up. I may die from germs. Once you're able to boss back OCD in a particular situation, you need to have the youth to understand they're always going to need to do that. Because if they go back to avoiding, if they go back to listening to OCD, then that bully is going to take over again. And for them to understand that in order to take back control from OCD, you're going to have to accept uncertainty and feel anxious. So as therapists, what are some key points here? Well, the content of the obsession is irrelevant. You want to go after the core fear. So a fear of hurting someone, a fear of being a bad kid, and a fear of throwing up, a thought, they're all the same. We go after them with the same tools. And that acceptance of uncertainty and doubt and the willingness to take risks is a key component of ERP. You want to make sure that you go where OCD takes you. You want to get to those 10s on the fear hierarchy. You also want to be very mindful of where that youth is. Sometimes we have to use sort of kid gloves. Other times there's this push and pull kind of treatment. You want to make sure that there's no distractions or reassurance happening during ERP tasks or even in sessions, especially that subtle reassurance seeking that happens. You want to help them recognize and negate all mental compulsions, and to make sure that they're going after OCD in planned ERP, day-to-day ERP, imagined, and in vivo. And that repetition and consistency is super important, that it ensures the between and within trial habituation, and that's what's needed if we're going to retrain that amygdala and then stop the false alarm. All right, well, thank you very much. And I guess I will stop my share and we can open it up for questions if there are any.
Thank you, Dr. Sapp. There is a question in chat already. I don't know if you can see it.
No, I haven't opened it yet. Let me open it up.
I'll let you read it.
Okay. How do you help clients accept or be okay with uncertainty that their core fear will come true? Any strategies you use here? Okay, yes. So that's a really good question because it's very hard to do it. Their core fear often or can be quite scary. So there's a couple ways that we can do this. First of all, I have them understand that I'll do sort of like one educational component where we will understand that in here, we know that you don't want to hurt your mom. In here, we know that you're not a bad kid. But up here, what we say to OCD and what we do and how we respond back to that obsession is going to be opposite. It's going to be the tool that you're using to fight back OCD. So that's part of it. I will also use sort of telling stories about the whole idea, really understanding that what we're doing here is we're retraining that amygdala, and that the content and talking about it doesn't really matter. So I have sort of several analogies. I don't want to go through them here because I don't have the time, that I'll use to sort of help them understand. One of the big ones I use is that if we continue to argue with OCD and, you're a bad kid. No, I'm not. Yes, you are. No, you're not. It's just going to keep on going. But if we sort of agree with it, you're a bad kid. Well, maybe I am. You've kind of stopped. And so that's kind of an analogy I'll use that helps them understand that. Next question, how do you measure the 50% decrease in anxiety during ERP? Okay, so basically with ERP, there is the fear scale, anxiety scale or fear thermometer. So when they are first being exposed to the trigger, we're going to let them be exposed, feel that anxiety, and then ask them, where are you on your fear thermometer? They might say, I'm at a 4, and then we would stop the ERP task when their anxiety comes down to a 2. So we're using that scale. So there's a lot of questions here, so I'm trying to find which one to start with. How to deal with clients who have a fear of something bad will happen if I talk about it. Hard to plan exposures without acknowledge of fear. So that's a good question. One of the things that will help in this is the tricks that OCD plays. And so helping them understand that just because I have a fear or have a thought doesn't mean it's going to happen. So again, and in the first webinar, I talked a little bit about the tricks that OCD plays. And so by that first piece where I'm really educating and helping them understand what's going on in the brain and helping them understand OCD, then they start to be a little bit more willing to talk about it. I have to get them to trust me as well, and that will get them more likely to talk about it. So generally, I get them to the point where they will acknowledge the fear. Sometimes I might just use stories of other clients to kind of get and say, it sounds like this is what my client, I give them stories and sort of see if they can relate to it. And then that's another way I'll get them to acknowledge the fear. What tools can we use to train kiddos to resist mental compulsions? Okay, so there's no real tools. The big thing around mental compulsions is bringing back the fear. So I teach them that what a mental compulsion is. I teach them that what it's done is brought down that anxiety, and I help them understand what it is. Once they know what it is and that it's something they're doing in their head, if they're pushing it away, then I just teach them that we have to bring it back. And we can do that by saying our fear statement. So if I have a mental compulsion of pushing away the idea that something bad could happen to my mom, then I would have them come back and say, nope, it could. So there's I don't have any sort of concrete tools, but it's just teaching them a new way of talking back to OCD. So that's not true. I might use thought bubbles. I might have OCD kind of saying something and then the new way of talking back. So teaching them different ways to, instead of doing the mental compulsion, what do you say instead? Is it okay to use distraction if the ERP the client is working on feels too anxiety provoking, if it feels like an 8 or a 10 on the fear thermometer? So first of all, we don't want to be doing ERPs where the anxiety is that high. So sometimes though, we get in a situation where we don't know that that's going to happen, and it ends up that the anxiety is very high. So if I accidentally get my client in a situation where their anxiety is an 8, then what I'm going to do is have them try to sit with it at least till it comes down to a 7. And then as soon as it's a 7, then we would get out of that and we would reevaluate of how do we go after that same fear we were going after in that particular ERP at a level that they can manage. Okay. Let's see. Oh, can you speak to exposures for sensory motor OCD, like swallowing and blinking? So sensory motor OCD is where people will have, they just are constantly thinking about behaviors that they are doing. So blinking, and they continually think about blinking. They can't stop thinking about blinking. And so in terms of exposures for that, again, we want to identify what that fear is. Often it's a fear that I'm not going to be able to stop thinking about this and I may go crazy from it. Or it could be that other people are noticing. So we really, again, before we can develop the exposure, we need to know what the fear is. But once we know what that fear is, then we can develop an exposure. So basically with sensory motor exposures, we would want to have them focus on that sensation. I've had people where they will be focusing on, blinking. So it might be that I might look at look it up on the internet and see if we could find like a GIF of blinking or some eyelashes going crazy or something. So I might start there. And then we might start to then have them focus for a period of time on their own blinking and sitting with the fear of that it means that they're going to go crazy, that they're not going to be able to think about anything else or whatever that fear might be. Sorry, I'm trying to find if there's any other questions here.
I have a question, Dr. Sapp.
Sure.
With regard to teenagers, how much do you involve the parents in ERP?
Oh, well, I find that it's going to depend on, first of all, the relationship that the teen has with their parents, and the age of the teen. Sorry, this is coming up. So basically, what I'd like to do is I always will involve the parents in the educational piece. So I need them to understand what's going on in the brain. I need them to understand what is, why we're going to be doing ERP, why we're going to be actually responding in such an opposite, crazy way, because it does feel very counterintuitive. So I need them to be involved with that. Secondly, I want to kind of look at them as coaches, and the relationship that they have with their parents will determine how much of a coach they're going to be. Often we need to find out if parents, like I was saying before, whether what their responses are might be maintaining the OCD, and then we'll have to involve them to try to make changes in their responses. So with teens, I'll bring the parents in and it will be kind of done together. And finally, I do find that if the teen is not wanting to do ERP, especially the planned ERP, then I'll see if I can get their permission to have the parents involved by sort of triggering them, and that we incorporate more day-to-day ERP as a way to still go after the fear.
Okay, thank you. I don't know if there's another question there I can ask.
Let me look if there's another one.
Because you talked about the push and pull of treatment. How do you know when to push the youth and move them up the ladder or push back?
So that piece is basically depending on how much distress the youth is experiencing. So first of all, if they're experiencing a lot of distress, or if the severity of their OCD is quite high, then there's going to be a lot, especially at the beginning of treatment, a lot of that kid gloves. So I'm not going to be pushing them very hard. The other piece is where, even when we're figuring out what that ERP task is, if they're doing a task and I'm recognizing that they don't look too anxious, then I might start to put something, make it a little bit harder and move them a little further up the ladder. But another really important component to that is where we are in the treatment process. So I am not going to be pushing my clients that I've just started with. There really has to be a good relationship, a good therapeutic relationship, and also a good trust. They need to trust me. And so, I can't tell you how many of my clients that later on in treatment, they've been doing this amazing ERP. And I sort of say to them, what do you think would have happened if we had done that? If I had asked you to do that at the very beginning of treatment? And they're like, wow, no way. I would have run out of here. So it really is part of the trust and figuring out where they are in the process.